Following video is a description of the technique utilizing both endoscopic and open approaches for the repair of hamstring tendon tears. First, the patient is placed in the prone position, ensuring appropriate padding of all bony prominences. Towels and pillows are placed under the legs to keep the hip extended and the knee flexed to minimize the tension about the hamstring tendons and the sciatic nerve. Relevant anatomical landmarks, including the borders of the ischial tuberosity, are marked. The direct posterior portal is marked distal to the ischium within the gluteal fold approximately 2 centimeters medial to the lateral aspect of the ischial tuberosity, and the posterolateral portal is marked roughly 4 centimeters from the medial portal, again in the gluteal crease, just lateral to the lateral border of the ischium. The portal incisions are planned in such a way that they may be later connected to create the incision for the open approach. After marking the portals, the arthroscope is placed into the direct posterior portal, and the posterolateral portal is made under direct visualization, coming in at the lateral border of the ischial tuberosity, being mindful of the position of the sciatic nerve. Once these portals are established, an arthroscopic shaver is inserted into the posterolateral portal, and a bursectomy is performed in the subgluteal space around the ischial tuberosity to improve visualization and facilitate identification of the hamstring tendon tear. After identifying the retracted tendon stump, attention is directed toward locating the sciatic nerve for protection. The posterior femoral cutaneous nerve branch is often the first branch encountered and is typically found distal and lateral to the lateral border of the ischial tuberosity. The sciatic nerve can then be identified more proximally and is typically lateral and deep to the posterior femoral cutaneous nerve. Each of these nerves are then exposed through blunt dissection using a non-toothed shaver, ensuring appropriate protection and mobilization of the nerves. Next, any surrounding adhesions to the hamstring stump can be gently debrided with the use of an arthroscopic shaver. After appropriate exposure of the tendon stump, the soft tissue surrounding the ischium are debrided using a radiofrequency ablator, and the footprint is decorticated with a 5.5 mm cylindrical burr to enhance the biological healing response. Following preparation of the footprint, two 4.75 mm PEEK suture anchors are tapped and placed at the previously prepared footprint. Each anchor is triple loaded, resulting in a total of 6 suture limbs that are passed through the lateral portal after each anchor is placed. After placement of the anchors, the instruments are removed and an incision is made between these two portals to expose the repair site. The gluteus maximus fascia is first identified and incised. The soft tissue playing deep to the gluteus maximus and superficial to the hamstring tendons are bluntly dissected, and deep retractors are placed to aid in visualization. Once identified, the hamstring stump is secured with a stay suture, and further blunt finger dissection can be performed to ensure appropriate mobilization of the hamstring tendon. Next, the suture limbs from the two triple-loaded anchors are separated into the post and non-post limbs. Each of these non-post limbs are passed through the hamstring stump in a running, locking fashion from proximal to distal on the lateral side and from distal to proximal on the medial side, exiting the superficial surface of the tendon toward the surgical field. Once completed, all the post limbs are passed once through the tendon, also exiting superficially towards the surgical field to ensure appropriate compression of the tendon stump on the footprint upon knot tying. Next, using a docking technique, tension is then applied to the post limbs and the tendon is reduced to the ischial tuberosity. Each suture pair is subsequently tied and the suture strands are cut. The arthroscope can then be reintroduced to evaluate the repair and ensure there is no undue tension on the sciatic nerve.